Maintaining euthermia in very low birth weight infants, less than 1,500 grams during the golden hour. This is the Quality Improvement Initiative by the Children's Hospital of Philadelphia Newborn Care Network. At Einstein Montgomery. The golden hour is defined as the first hour of postnatal life in both preterm and term neonates. The first 60 minutes of life encompass definitive critical care that has a direct impact on both short and long-term outcomes for these infants. The golden hour includes resuscitation, transportation, and initial stabilization of the infant in the NICU. We are trying to improve by increasing the number of very low birth weight infants, less than 1,500 grams, who have normal axillary temperatures on admission to the NICU, by improving our temperature management strategies at all points during the golden hour. In December of 2018, at the inception of this project, only 57% of all infants admitted to CHOP Newborn Care Network NICUs had normal axillary temperatures. Our goal by July of 2019 was to have 90% of all infants admitted to the NICU across all of the CHOP network sites within the network. Why is preventing hypothermia important? Primarily because the incidence of hypothermia is very high in infants less than 1,500 grams. Hypothermia decreases the chances of survival of a very low birth weight baby significantly. Hypothermia is associated with hypoglycemia and metabolic acidosis, impaired surfactant production and increased rates of respiratory distress, impaired immune function and increased risk for neonatal sepsis, impaired coagulation, which can lead to intraventricular hemorrhage and risk of pulmonary hemorrhage, poor neurodevelopmental outcomes, and bronchopulmonary dysplasia. The chart on the right of this slide shows the degree of increase of the risk of death with even mild hypothermia, 2 times a higher risk of death, and severe hypothermia, 10 times higher risk of death in babies that are born less than 1,500 grams. The temperature goal is to achieve euthermia, meaning that we maintain temperatures between 36.5 and 37.5 degrees Celsius. For infants less than 1,000 grams, temperatures less than 35 degrees Celsius are associated with severe hypothermia and poor outcomes. If not actively protected from heat loss, the infant's temperature may drop as quickly as 0.2 to 1 degree centigrade per minute. Why are small babies at risk? There are several reasons. Rapid heat loss occurs in premature infants or low birth weight infants because they have limited to no ability to produce or even begin to conserve heat. They have an increased body surface area with a large surface to body mass ratio and weak muscle tone with poor flexion, which prevents them from actively generating heat. They have thin, immature skin with a poorly developed epidermis and stratum corneum. And there's a barrier dysfunction which allows for large transepidermal water loss. They have a poor ability to vasoconstrict, so the blood reaches the skin surface easily and quickly where heat loss occurs. During cold stress, several important physiologic responses occur. There is release of norepinephrine, which increases the infant's metabolic rate. Metabolic acidosis results from anaerobic metabolism, increased glucose utilization, and decreased oxygen delivery to the tissues, resulting in hypoxemia. The ultimate result from metabolic acidosis is threefold, including hypoglycemia, cardiovascular damage, and neurologic damage. During hypothermia, the increase in metabolic rate results in increased oxygen consumption and increased glucose utilization. Increased oxygen consumption results in low levels of oxygen in the blood, or hypoxemia, and subsequently in the tissues, or hypoxia. When glucose utilization is increased, hypoglycemia results. The combination of hypoxia and hypoglycemia result in anaerobic metabolism processes, lowering the pH of the blood. This lowered pH ultimately causes cardiovascular compromise and neurologic compromise. Cardiovascular compromise includes a lowered heart rate, lowered blood pressure, and decreased perfusion to the tissues. Neurologic compromise is primarily characterized by an increased permeability of the blood-brain barrier, resulting in hypoperfusion, reperfusion injury. Cardiovascular compromise ultimately results in impaired heart contractility and in impaired heart function. The combination of the impaired heart function and the hypoperfusion-reperfusion injury increases the risk of intraventricular hemorrhage. How do newborns lose heat? There are 4 mechanisms of heat loss in newborns: conduction, convection, evaporation, and radiation. Conduction is defined as heat transfer between two objects in contact with one another, as exemplified by placing a warm baby on an unheated surface. Convection involves heat loss by air currents, and examples of convective heat loss include a cold room, sides of a radiant warmer down, portholes open, or cold inhaled or blow-by oxygen. Evaporative heat loss occurs when moisture turns to vapor, such as when a newborn infant is exposed to the extrauterine environment after being enveloped in water or the amniotic fluid. Radiation involves heat transfer between two surfaces that are not in contact with one another, such as when there is a bed near a cold outside wall or window, a temperature probe that is loose that results in heat gain, and radiation provided by a warmer that is set on manual mode. Preventing heat loss involves actions related to the type or mechanism of heat loss. To minimize conductive heat loss, pre-warmed blankets, a pre-warmed bed, pre-warmed hat, stethoscope, and hands all contribute to minimizing conductive heat loss. Convective heat loss can be prevented or minimized by keeping the sides of the radiant warmer up, the portholes or doors on the incubator closed, and by increasing the ambient room temperature. Evaporative heat loss can be prevented or reduced by removing wet linens or blankets from the baby quickly, by utilizing a plastic wrap or polyethylene raincoat, and by providing humidity in an incubator. Mechanisms of radiation heat loss can be minimized by using servo control on the radiant warmer or in a warmed isolette by securing the temperature probe with an appropriate sticker, and by keeping the bed away from windows and walls. How do we prepare for the delivery of a very low birth weight infant? Prior to delivery, the temperature in the delivery room should be placed at 74 to 77 degrees Fahrenheit. You should feel hot. Ensure the bed that is set up appropriately for the preterm delivery, including warm blankets, a hat that is being pre-warmed, a thermal mattress, and plastic wrap or raincoat. Pre-warm the bed using the manual mode set at 100% heater output, and activate the chemical thermal mattress at least 5 minutes before delivery and place the blanket over the thermal mattress. So to summarize, you need 4 critical items: warm blankets, warm plastic wrap, a warming hat, and an activated thermal mattress. You also need a room temperature that is between 74 and 77 degrees Fahrenheit. How do you keep a baby warm during delayed cord clamping? Immediately wrap the baby in a dry, pre-warmed blanket, being sure to cover both the limbs and the head. In the case of C-section, use sterile warm blankets and a hat on the field during delayed cord clamping, and have a second set of warmed blankets either available for use on the sterile field or upon arrival to the resuscitation bed. In many institutions, the pre-warmed polyethylene wrap or raincoat is kept sterile and is placed on the sterile operative field immediately before the delivery of the infant, and the infant is placed immediately into that sterile wrap without being wrapped in sterile blankets prior. During stabilization, as we said, immediately wrap the baby in pre-warmed blankets, cover the head and limbs, and transfer to the pre-warmed bed after delayed cord clamping. If you choose to use the polyethylene wrap on the sterile field, do not dry the infant, but immediately put the baby into the polyethylene wrap during delayed cord clamping and transfer the baby from the sterile field to the resuscitation bed with hat applied and in the sterile polyethylene wrap. Place the infant on the chemical warmer mattress that's already been activated on the pre-warmed bed, and be sure that the infant's head has been dried, and replace the hat with another pre-warmed hat if it is wet. Take and record the infant's axillary temperature every 15 minutes after delivery during resuscitation through the admission to the neonatal ICU. Secure the servo-controlled temperature probe with an insulating cover or sticker on the abdomen, and change the warmer to the servo control set at 36.5 degrees centigrade. Assess the infant through the polyethylene wrap during the initial stabilization. During transport and admission to the neonatal ICU, use an Omni bed with an external heat source from delivery to admission if available. If an Omni bed is not available, transport the infant in a preheated transport incubator in the polyethylene wrap, and be sure that the incubator has been pre-warmed on the servo control set at 36.5 degrees centigrade. Closely monitor the temperature during transport and utilize all strategies to prevent hyperthermia. Provide humidity for infants with a birth weight less than or equal to 1,000 grams or less than 30 weeks by using an incubator that has a humidity source. Keep the polyethylene wrap in place during procedures if those procedures are needed, including umbilical line placement. Once the baby has been stabilized and umbilical lines or other procedures have been completed, remove the plastic wrap. How can we achieve success in maintaining euthermia in very low birth weight infants? Doing so involves teamwork, communication, care coordination, policies and protocols, and ongoing education and training. Teamwork involves pre-huddle assignment of roles and a post-huddle debriefing to review what went well and what opportunities there are for improvement. Be sure to speak up, as everyone's voice and perspective is valued and important. In terms of care coordination, good record keeping and the use of checklists is paramount. Policies and procedures exist at Einstein to review all the steps in thermoregulation and the golden hour protocol. Ongoing education and training here is data-driven and based on the evidence, and includes both practical simulations and drills, as well as individual review of mandatory education, PowerPoints, and lectures. The key points to remember include that all infants are at risk of hypothermia, but preterm infants are at highest risk. Preventing hypothermia is much easier than overcoming the detrimental effects of hypothermia once they've occurred. One must ensure appropriate environmental, material, and personnel preparation for every delivery, and check the axillary temperature every 15 minutes during stabilization in the golden hour. Maintain a warm chain during transport, meaning that during transport, all strategies are utilized to minimize the 4 major types of heat loss. Prevention of hypothermia is teamwork, and pre-huddle decreases role confusion, increases efficiency and effectiveness in achieving and maintaining euthermia, and ultimately improves patient safety. This is a listing of 5 important published manuscripts on maintaining and achieving euthermia, including some specific protocols and quality improvement projects. I invite you to access them and review them as needed. Most importantly, thank you for all that you do every day to maintain euthermia, especially in our very low birth weight infants.